Hi, everyone. This is Caroline from Fiat Integrative Health in Franklin, Tennessee, and you're listening to the Fiat Health Podcast. We believe that now more than ever, the healthcare industry has become a place of confusion. And over the years, we have been asked countless questions about what true health and integration for the whole person looks like. Join us every other week as we explore topics ranging from primary care and women's health to counseling and spiritual health. We're so glad you're here. Hey, everybody. Welcome back to the Fiat Health Podcast. My name is Caroline, and I'm a family nurse practitioner. Today, I am joined by Amanda Frederick. Hi, Amanda.
Hi, Caroline. How are you doing?
I'm good.
Good.
Amanda is one of our women's health nurse practitioners here at Fiat, and today we are going to talk all about infertility.
Yes. So wanted to start off by talking about our new training that a lot of our providers have gone through now. We have everyone in women's health now certified in Neofertility, which is a restorative reproductive medicine practice that was founded by Dr. Phil Boyle. And it is something that we are very excited about in our practice. So it has given a lot of organization to our fertility process so that we can help women get to the root cause of their fertility problems and in a stepwise process, give them what they need to be successful.
Right. So right now, if somebody is experiencing infertility, which maybe actually would be really good for you to tell us, like, what exactly is the diagnosis of infertility, right? Like, how some people are like, am I dealing with infertility? Am I not? So what would qualify someone for that?
So typically, infertility for women under 35 is trying to conceive for 12 months with regular intercourse without success.
Mm-hmm.
And then over 35, just because time is of the essence, we give it 6 months or less for trying to conceive.
Mm-hmm. And so, typically people will go to their OBGYN or to a GYN and say, it's been a year, 6 months, I've been trying to conceive. What's the typical route that people, like, what would an OBGYN typically do for them?
It really depends on the OB and how comfortable they are with fertility treatments, ovulation meds, that sort of thing. But what I've heard a lot from clients is a simple workup. Some OBs will go as far as to do an HSG or tubal dye test to make sure the tubes are open, do some basic hormones, thyroid testing, glucose, basic lab panels. And then a lot of women are offered Clomid or Letrozole, these ovulation meds, for a very short period of time, like 2 to 4 months typically.
Mm-hmm.
And then if they're not successful, often they are referred to a IVF clinic.
Mm-hmm. And so as opposed to that approach, if someone comes to us without any, let's say, any previous workup at all, they're just like, I've been trying for 9 months, for a year. What would we typically do, like here at Fiat?
So our first step is to do a barrage of labs. Lab work tells us a lot of things. So we do 2 sets of labs. We do the cycle day 3 to 5 labs, and then we also do luteal phase labs. And what this shows us is what is going on in the first half of the cycle, what is going on in the second half of the cycle. And then simultaneously, we recommend they learn to chart using a fertility awareness method or other type of tracking, and then have a male fertility evaluation, a semen analysis to start with. That's what we typically start with for the initial workup. And then I always give them the fertility diet information, exercise, what lubricants are fertility friendly, sleep recommendations for timed intercourse, kind of those upfront things that nobody tells you that you're supposed to find out in your own research.
Yeah.
Just as an easy, here you go, this is going to help you be more successful.
And so cycle day labs, like you said, at the beginning of the cycle, post-luteal, how many people would you say come in knowing how to track their cycle already?
Probably 50%. Most women who have had any time in trying to conceive have already read a couple books, gotten access to some apps. And so they have some idea of tracking. Detailed fertility awareness methods that are helpful for trying to conceive usually are a bit more of a learning curve than that. But I do find that there are a lot of women who are like, hey, I've got these 3 apps. I understand cervical mucus. I understand temperature checking. What else do I need to do? And we usually have to kind of meld together a tailor-made plan for them rather than send them to a lot of continuing education because they usually do know a lot of what's going on.
Mm-hmm. Do you typically recommend monitors like Anito or Mira or anything clear blue?
So my favorite fertility awareness methods are Neofertility and Creighton. But there are some people that are not particularly suited for those methods. People who don't produce a lot of cervical mucus, sometimes people who find the education to just be sort of a rough learning curve that makes it harder for them than easier. In those cases, I do like Mira and Anito because it takes the guesswork out of it when you don't have cervical mucus to go off of. Those are good. I also like just basic pre-mom ovulation strips. They come with an app where the app will rate how dark they are. And that's really helpful too, just to get an idea of when LH is rising or ovulation's occurring.
Mm-hmm. Yeah, I've found even personally, it's great to have a monitor if you're just lack confidence. You're like,
Yes.
I think I know what I'm seeing here and my different fertility signs, but I'm just not totally sure. So it's really nice to have a monitor to back me up to be like, okay, yes, what I am seeing is actually right.
Absolutely. Absolutely. And it's also really fun to just be able to screenshot it. And especially when we're doing very detailed cycle specific labs and ultrasounds, I'll get screenshots, multiple times in a week from someone. I can just be like, yep, that's when you need to go rather than there being a lot of guessing and frustration.
Yeah, absolutely. So walk me through what something like that would look like. Like, let's just you can even think of a real patient example of someone trying to conceive. So I also think a lot of people come in not realizing how much work it is. There's a lot of labs, there's a lot of ultrasounds, there's a lot of, potentially. So maybe walk me through what that process is. Pretend I'm completely naive. Now I'm trying to get pregnant. What would that look like?
From the beginning, as soon as we get lab work back, we go through a lot of detailed interventions. And so that first phase is kind of the evaluation phase where you may have to start quite a few meds and supplements. The diet and lifestyle recommendations, we usually recommend a modified Mediterranean diet, exercising up to 6 days a week, ideally. Those are hard things to implement, but they really are necessary in order to be as successful as possible. So those are difficult things. And the tracking also, all of these things go into timing meds and timing interventions. And the timing in restorative reproductive medicine is what is so important. It's not a one size fits all. It's about the individual woman's cycle. So the more information we have and the more committed to lifestyle modifications, supplements, medications the patient is, the more successful they are going into it typically.
And so, you do that initially eval, we get some blood work back. What would be, just an example of somebody, then would that lead to, for instance, follicular ultrasounds? How many, are we getting labs every single cycle? Like, how do you typically do that?
Yeah, so we have a stepwise approach, and this does come from Neofertility, where the first phase is that assess and prepare. The second phase we call boost and balance, which is usually about 2 months of implementing supplements, medications, and doing follicle tracking. Now, what follicle tracking is it's 2 ultrasounds in a cycle. One's done typically about 2 days before average peak, and the second one's done 3 days after. And what we're watching is a follicle developing in the ovary, and is it releasing as it should? Because a lot of people can say, oh, from my fertility awareness method or from my monitor, I'm ovulating, but you don't really know someone's ovulating until you watch it on ultrasound. And so that's the purpose of the follicle tracking. And then after that, that's when we call it the conception phase. And that's when we target 12 to 16 cycles where we watch every detail of the cycle every month. So sometimes patients will take breaks from this because 12 to 16 in a row is a lot of cycles. But typically what it looks like is we have interventions in the follicular phase, sometimes triggers, and luteal phase support like progesterone or sometimes HCG, depending on what the labs show. And we watch that with labs. So we watch the labs every cycle. We do the labs between peak plus 6 and 9. And what that tells us is, are we getting a good estrogen and progesterone response? And if we're not, we know our interventions aren't working. And so we base the next cycle's interventions on those labs. And then we'll periodically do ultrasounds as well. Typically, the ultrasounds are not every cycle, though.
Okay. Wow. Super fascinating. And I can definitely see how it would really be hard to like keep doing it for many, many months, But typically, I know when we've talked before, just as setting the expectation for people, you would say like 12 months probably, right?
Yeah, 12 to 16 cycles, depending on what we find. Sometimes in some situations, we're finding a new diagnosis every couple cycles. And so I've definitely reset the clock and said, okay, we just found a really significant thing. I think that was in the way of your fertility treatment before. So let's start the clock at 0 or start the clock a little bit earlier since we have this new issue that was so prominent. We definitely had a patient who had a prolactinoma that was diagnosed midway through fertility treatment. And that pretty much set her back at cycle day 1 or, cycle number 1.
Right. What are some other things that you typically find in patients in their fertility journey?
In restorative reproductive medicine, we believe that there is no such thing as unexplained infertility. I've never had a patient with unexplained infertility. We always find something. Often we find lots of things. In the initial workup, you can find things like thyroid disease, insulin resistance, luteal phase defects, where maybe the ovary isn't producing the right amount of progesterone and estrogen, or follicular phase defects where the follicle isn't developing well enough to get good hormone production at the end. Thin uterine lining. There's other things too, like low male hormones, low AMH that's leading to a diminished ovarian reserve, PCOS, very common, endometriosis, which is diagnosed via surgery, but many times we can see the signs of that right up front. Those are the very common things, but we've gotten to where there's also uncommon things that are coming up now. One that has been particularly fun to treat, actually, because it's a very successful treatment, is women that have low T3, which is a thyroid hormone, but it's not the thyroid hormone that you usually hear about. It's the other one. And we found that by just treating their low T3, we've had extreme success with this in our practice of people getting pregnant even the next cycle on that treatment. Other things like chronic endometriosis, which is inflammation of the uterine lining that can sometimes be caused by bacteria or viruses, but some people just have autoimmune predisposition towards inflammation. So you've got that aspect. Clotting disorders, diminished sympathetic tone, lots of weird things that can come up as well that can contribute also. And so we've started deep diving into those, that just because we find one thing on those initial labs doesn't mean that there might not be more waiting to be found.
And specifically with the Neofertility, like how has that really shaped our approach to fertility? And how is it different from mainstream OBGYN and as well as even other like integrative functional fertility space?
The thing about Neofertility that I have really found to be very helpful is it's meant to not only be a method, but an organization process. And so in restorative reproductive medicine, we have a lot of information coming in as this specialty has gained a lot of bandwidth in the last couple of years and is growing, but it's hard to organize that information. I'm naprotechnology trained. We've got this big 2,000-page textbook, hard to figure out how to organize that information. But what Neofertility does is it breaks it down into these stages, like I said, the different phases of treatment and a very stepwise approach to things. So the male hormones, especially, that's something that Neofertility really treats very aggressively, is to make sure that estrogen levels are optimized for pregnancy, improving fertility, but also preventing miscarriage. And a lot of these more obscure things that we're looking at right now, like the T3 therapy, like food intolerances contributing to infertility and inflammation, those are all things that Neofertility really emphasizes in a way that I feel like wasn't necessarily emphasized as much in previous education that I've had, at least.
Yeah, absolutely. And then, too, I feel like, pregnancy management, is that also part of neofertility?
Yes. So we've been doing the estrogen, managing estrogen levels in pregnancy for about 2 years at Fiat now. And that came from neofertility. So it is part of that education as well. But we've actually been implementing it for a lot longer than we've had this education. And it's been an amazingly successful venture for sure.
And I feel like pregnancy management is such a unknown thing. I think a lot of people don't realize, it's like, okay, yeah, you got pregnant, like, so great, amazing. And then they're like, oh, and now we're still going to do a lot of work.
Yes. Yes.
Like, that wasn't the end of the story. We want to make sure you get through your first trimester and your second and all the way to a healthy full-term baby. So maybe walk us through what that looks like. Because I think anyone outside of the IVF world, I know in IVF, they do some like pregnancy management.
Yeah.
I think is completely unaware that this even exists, especially people with recurrent loss, right? So this is not even infertility per se, but, people who have no problem really getting pregnant, but then when they do get pregnant, they have many losses. So maybe walk us through what that management looks like and what we've seen in our patient population in our clinic.
Absolutely. So pregnancy management is something I'm very passionate about because just because someone can get pregnant does not mean they can stay pregnant. And that's a problem for a lot of people, especially people who have dealt with infertility, because just because you get to that point of a positive pregnancy test does not mean all of a sudden your body's going to know exactly what to do. And so a lot of our fertility treatment also hinges on as soon as they get a positive pregnancy test, they need to call us. I have, people texting me, and I don't know why. It's always Saturday morning people get positive pregnancy tests. And so they are instructed to text us as soon as they get a positive. And so we do a thyroid evaluation, estrogen, male hormones sometimes, and progesterone and HCG. And our progesterone protocol is tried and true from the St. Paul VI Institute. We've been using that for years, and that is how we manage progesterone. The estrogen protocol comes from Neofertility, and we will manage estrogen levels to make them optimal. We don't risk it. So if you have an abnormal estrogen, you're going to get treatment for it. But then the thyroid, that comes from clinical practice. I had a patient who had a recurrent loss history, 2 losses, both at 6 weeks, couldn't figure out what was wrong. All of her initial labs were normal, didn't have any trouble getting pregnant. And so we decided to just check her thyroid every week in pregnancy. And 4 weeks it was fine, 5 weeks it was fine, 6 weeks when she would have otherwise had a loss is when the thyroid dipped. And we put her on thyroid medication. She had her first full-term pregnancy. That's the only thing we did was just the monitoring. And so ever since that happened, we now check thyroid 4, 5, 6 weeks just to make sure that we're not watching it take a dip, because the thyroid is under a lot of stress in pregnancy. It has to work harder. And that seems to be what was causing her losses, is that right around 6 weeks, her thyroid just couldn't keep up. So that's what our initial pregnancy management looks like. We've expanded it a bit more now that we have a lot of more higher risk patients with recurrent loss. So if I'm seeing a lost patient and we haven't gotten to the bottom of it, we'll do the clotting disorders in the first couple of weeks of pregnancy. We'll do infection testing. We'll do natural killer cells. We'll look at different things that could have contributed, because I don't want them to have a loss just because we didn't get to the bottom of the workup. And we have had quite a few people recently come back 5, 6 weeks pregnant with these new results where we've had to pivot and, intervene with Lovenox or prednisone or even antibiotics for infection just to help them keep a healthy pregnancy. But it works. It just requires some time-intensive management for sure.
Yeah. And what about, what would be a patient, you were telling me about one, that's why it's on the top of my mind, who had potentially, right, I don't know for sure, an underlying infection and had a loss previously. And then, her midwife or her OB wasn't going to treat it. Tell me about that again. That was really fascinating.
Yeah. So we've had this come up a couple times recently, where a patient tests positive for a bacteria like ureaplasma or mycoplasma. And typically, the ACOG guidelines do not necessarily push treatment in pregnancy if the patient's asymptomatic. And so she didn't have any symptoms. So her OB was like, oh, well. But she had had a loss, and it was a late loss. It was not a first trimester loss. And there was no explanation for it. And she had gone into spontaneous labor. And so I said, well, it could have very easily been this bacteria that's been sitting around. So let's go ahead and treat it. And we ended up treating multiple times in pregnancy. It would not go away. So I think she had like 3 rounds of antibiotics in pregnancy. But I think she's due to deliver very soon. So we were able to get her to the 3rd trimester healthy. And that's come up a couple times now, again, where we have these recurrent infections showing up in pregnancy. So just being really on top of things with that to try to help people get their full-term pregnancy.
And I think one thing that really stood out to me that you said last time was, we do not accept anything less than perfect.
Yes. Yes, that has come true throughout my practice. I used to think, oh, well, if we were just good enough. But there are definitely situations, and T3 therapy is a good example. Dr. Boyle and Dr. Hilders all recommend a T3 to reverse T3 ratio of 10. And I never quite understood why that was so necessary before, but we've started insisting on the ratio of 10 with T3 therapy. And I haven't kept track exactly, but I think it's something like 15 or 20 people got pregnant on the next cycle after starting T3 therapy at that ratio.
Wow.
And
that's
like
just our patient.
That's just our patients.
Yeah.
And I started noticing that, and we just started doing it last September, October. And it was literally like every couple of weeks, I'd have another person I put on that therapy test positive. And so perfectionism does go a long way for sure.
So awesome. So now we have all of our women's health providers have done Neofertility. Is there anything that you want people to know in terms of just coming here and the care that they'll get, what to expect, or maybe even red flags that would be you should definitely come now instead of later, let's say?
Absolutely. So in terms of expectations, I think the cool thing about this training is it has now standardized women's health at Fiat. So if you're coming here for fertility, you are going to see providers that have the exact same training, the exact same steps, the exact same method. And so there's a lot of standardization. So there's no reason to call and say, I want to see, somebody in particular. Everybody has this understanding, this training. And the cool thing is we also collaborate. We do a lot of collaboration. So there's a lot of communication and constant ongoing learning. And I've been just completely impressed by the thirst for knowledge of everybody in the women's health department. Everybody is just ready to go find out the next thing, especially for their individual patient. And so if you're looking for care that is tailor-made for you and individualized, there's nothing like it. I'm so impressed with how this women's health department has developed in that respect.
Mm-hmm.
And you asked me another question. I can't remember what it was.
Oh, any major red flags, or just who should come and see us, right? Obviously, you've been trying for a year and you're under 35. That would be one reason to come see us. But maybe what are some other reasons?
So I think if you've been told that you have an unexplained infertility diagnosis, don't accept that.
Mm-hmm.
You very well may have something significant going on, but there's a name for it. We just have to dig deeper and find out what it is. So that is one. If you have a lot of period pain, I feel like endometriosis is something that gets missed a lot in regular medicine, because in IVF, a lot of times they're jumping over it. They don't have to fix it to get what they want. And endometriosis is a very complex condition, and there's good treatments for it. And people get pregnant naturally with endometriosis. You just have to have the right treatment. So if you have period pain, I would say that's another thing to consider restorative reproductive medicine for. And then women who are trying to conceive over the age of 35 are often not given a lot of options in the regular reproductive world. They're pushed straight towards IVF or straight towards a lot of medical intervention. And there's a lot of things that can be done to optimize fertility naturally and to give your body the chance to to function naturally rather than skipping over it because of age.
And I know we see some people too who have failed IVF.
We do. We do see a lot of people, and that would be another group of people. Like if you haven't been given any other options, there is a lot of hope in restorative reproductive medicine, and a lot of women get healthier through it, regardless of the outcome. They're healthier and they have more knowledge of what is actually going on, which is important too.
Absolutely. Because obviously there are the cases where we find out, it is explained infertility, but we still aren't necessarily able to get pregnant, right?
Right. Not everybody is successful. That is true. But most of the time, even the women who aren't have that power of knowing, well, I know what was wrong. And now I understand my body and I'm healthier than I was before.
Yeah.
So that's
feel
a better for sure.
All those things. I feel like something we probably should have said at the very beginning, but that's okay, is what is restorative reproductive medicine? For us, it's like, blah, 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 like we say that words all the time. But I think probably most people are like, I've never heard of that before.
Yeah. So restorative reproductive medicine is women's health that gets at the root cause of medical problems. It isn't only limited to fertility. It applies across the board. In restorative reproductive medicine, we don't use birth control as a Band-Aid mechanism to fix women's health problems. We get to the root of what's going on. There's several different branches of restorative reproductive medicine, and now you've got just kind of random restorative reproductive medicine because it is a growing field where a lot of people are no longer sticking to one methodology, but just using everything. It's a growing field with a lot of different specialties represented. And we do stand as an alternative to IVF and the standard steps in terms of fertility care in regular Western medicine.
And it does, encompass more than infertility, right? Restorative reproductive medicine, is all things reproductive health, which, under that umbrella would be PCOS and, like you're saying, painful periods, like all of that.
PMS, mental health issues that are potentially hormonal, endometriosis, all of anything that can affect a woman is part of restorative reproductive medicine because restoring health can make all of those conditions better.
Yeah, all connected. Well, awesome. This has been so great, so insightful. I love that everyone on the women's health team got trained in Neofertility. I say this every time we do a women's health podcast that I'm so jealous because I want so badly to be in there, but I also know it's not where God's calling me. And I know y'all do just incredible work. So wonderful. So is there any parting words, anything else you want to share, Amanda, before we sign off here?
Well, when it comes to our staff here at Fiat, if anybody is interested in learning more about the Women's Health Program, they can contact our office. I know that the front desk has a lot of knowledge of what goes on in women's health, and also they have access to us. So we can answer any questions that you might have if you think that restorative reproductive medicine might be good for you.
Yeah, absolutely. And just to kind of piggyback on that too, is we have 2 support staff. We have Greta and Stephanie who work very, very closely with all of our women. They are dedicated to our women's health patients and our women's health team. And so, they are just so incredible. And I think absolutely, like if you're not sure, then just give us a call, because we can definitely walk you through and figure out, is this right for you? How does the process work? Because we do that initial assessment to begin with, and then we function in a membership after that. And so after we get that initial blood work and plan, you can decide if this is the right choice for you or not. We don't want you to sign up for a membership if you're not really sure if it's, the right thing or not. And then that membership allows us like such close communication and contact and texting and email. And, like Amanda mentioned, we just work so closely, especially with our infertility patients, to make sure we're getting all the information we need to be as successful as we can.
Absolutely. I'm glad you brought up Greta and Stephanie. They are a great resource also, and they'd be willing to answer lots of questions, I'm sure.
Oh my gosh, yes. Okay, great. Well, thanks, Amanda. This has been awesome.
Thank you, Caroline.
Thanks for listening to this week's episode. To learn more, you can visit our website at fiathealth.org. If you enjoyed this episode and you'd like to help support the podcast, please subscribe to our show on your favorite podcast platform and leave us a review. This helps make the podcast easier to find. Lastly, if if you'd like to reach out, ask a question, or suggest a topic for a future show, send us an email at media@fiathealth.org. God bless.